All right, let's bring this all home. Let's bring it all back together because everything is related to the endocrine system. Absolutely. No, it's not. So let's talk about a case. This is your patient, okay? She is an 84-year-old female with a history of dementia, Alzheimer's dementia. She's had frequent urinary tract infections. She's been to your emergency department about 37 times previously for a urinary tract infection, coming from a nursing home with a chief complaint of altered mental status. But you notice this time she really looks bad. You're looking at her and your sicko meter is really going off really, really heavily, okay? You look at her vital signs and they look like this. She's hypotensive, she's hypoxic. Get a temperature on her and it's low. And she's altered, so you being the astute providers that you are, you notice that the sepsis alert is going off. Because she's altered, she has all of the things that would normally make the sepsis alert go off with the temperature, the heart rate, blood pressure. So you start to do the normal things that we typically do. Start to warm her up, IV fluids, early antibiotics, IV vasopressors, but things are not changing. Her finger stick is low. You give her an amp of D50. The finger stick doesn't get better. Her mental status doesn't get better. Her vital signs don't get better. And start to think to yourself, what could be going on with this patient? Get labs, white blood counts elevated, lactates elevated. This is all screaming sepsis. Sepsis, sepsis, sepsis. Sodium is low, bicarb is low. You've given her some sugar and it's actually starting to correct a little bit. But now what's going on? She's not getting better. Her vasopressors are not kicking in. What is actually going on? Is this patient truly septic? Maybe it ain't just a case of sepsis. So what I want to impress upon you today is that, yes, we do see sepsis way more than we see decompensated hypothyroidism, but at least think about the diagnosis. And that's pitfall number one, not thinking about hypothyroidism in patients who have unstable vital signs. When these patients present, they very classically look like a sepsis patient. We see these patients all the time. They're going to be, most of the time, elderly females. They're going to probably be some element of altered mental status. They're going to have low temperature, low blood pressure. What is going to tip you off that this is not sepsis? Well, a lot of times what ends up happening is we focus so much on the sepsis that we forget about this tiny little gland right here in the neck that really has some significant importance. Because what the thyroid gland does is it expresses beta receptors, and beta receptors really help everything else work. So when these patients come in who are septic, we oftentimes see elevated temperatures and elevated heart rates when their blood pressure is low. In hypothyroidism patients, it's the opposite. Most of the time, these patients are going to have low heart rate and low temperatures, even when the sun is out. Most of the time, though, these patients do present in the wintertime, and we think, oh, they're just a little cold because it's cold outside and they were probably exposed. What we're doing here a lot of these times is we're missing the forest for the trees. We're focusing so much on the fact that they're septic and forgetting the fact that they are actually decompensated hypothyroidism. And the problem with that is that the mortality rate for this is relatively high. They estimate that the mortality rate for decompensated hypothyroidism is about 50%. I actually think they underestimate that number. I think that the number is much higher because what happens with these patients is they don't get diagnosed with hypothyroidism. They get treated for their sepsis. Subsequently, they may succumb from their sepsis, and their death certificate says sepsis. And so sepsis has this inexorbitantly high mortality rate. And what we're really probably doing is missing some hypothyroidism cases. So some clues that make you help or think about the diagnosis. Sure, if they have the thyroidectomy scar, if they have a scar across their neck, think about hypothyroidism. But the other thing is that these patients oftentimes, their brain is off. So a lot of people mistakenly think that these patients have to come in a comatose state. What what they actually look more like is they're apathetic. They're confused, but they don't really not just answer questions inappropriately, they just don't answer questions. They're awake, but they're not wanting to answer questions at all. And so some people rule out decompensated hypothyroidism, which is why I use the term decompensated hypothyroidism as opposed to myxedema coma, because people think if they're not in a coma, then they can't be in myxedema coma. And that's such a false thought to have. So we have to get out of that thought process. The other thing that we have to remember is that the thyroid affects a lot of other organs that can also make patients very unstable. And when the thyroid doesn't work that well, the adrenals don't work that well as well. And so 50% of patients who have decompensated hypothyroidism have a concomitant adrenal insufficiency, which can make their blood pressure low as well. The thing I want to impress upon you today is think about the thyroid. If we don't think about it, we'll never make the diagnosis. So a lot of us, as Dr. Swaminathan polled the room, have access to a relatively quick TSH. So if you can get a TSH in your department, in your ICUs, in your labs, this is a great way to make the diagnosis. But I agree with what Swami said. If you don't have access to it, what's one dose of thyroid hormone going to do to hurt the patient? Probably a whole lot. So I always say get the TSH just to make sure. And I've had a number of times where I've had hypotensive, hypothermic patients come in who I'm getting signed up from a colleague, and they'll say, yep, it's septic. Yep, it's septic. And I say, well, what's the TSH? And they'll say, oh, that's right. You're that guy. Okay, we should probably check a TSH. And I'm like, that's okay. I've already ordered it. So typically what you'll see is the TSH is up and the free T4 is down. We have a lab at our shop that's a free TSH with the reflex free T4. So if the TSH is abnormal, they'll send the free T4 automatically. If you have access to that at your lab, that's great. So pro number one, at least think about it. If you have a patient who comes in with unstable vital signs, a weird electrolyte abnormality, unexplained altered sensorium, think outside the box and just get the TSH. All right, so now that you have thought about the diagnosis and potentially made the diagnosis, now we got to treat the daggone thing. So how do we treat decompensated hypothyroidism? Brings us to pitfall number 2, not giving enough thyroid replacement hormone. Now, for those of us who have treated decompensated hypothyroidism, the classic teaching is to give anywhere between 100 and 500 micrograms of T4, or what's called thyroxine. Now, what's great about thyroxine is that it's safe for everybody. Thyroxine has not been shown to be harmful in any patient population. But remember that there's 2 thyroid hormones. There's T3, which is the active thyroid hormone, and T4, which is the inactive thyroid hormone. And when T4 gets administered into the body, it then subsequently has to be activated into T3 to actually start to manifest cause in the body. But what happens a lot of times with these patients who are in decompensated hypothyroidism is that their thyroid gland is actually turned off because thyroid hormone actually activates the thyroid gland. So if they are in decompensated hypothyroidism, they may need active thyroid hormone to activate their thyroid gland to actually start to help the body start to manifest and move in the right direction. So how do we do that? And Dr. Swaminathan alluded to, I say give both. And there's actually some really good literature on using combination T4 plus T3 therapy, using a lower dose of T3 and a lower dose of T4 together. And what that T3 will do is actually stimulate the thyroid gland to say, hey, the deiodinases that we need to turn T4 into T3 are made by you. So why don't you start getting to work and start doing some stuff? And it will actually help turn the later T4 into T3 to work on it after the fact. Why don't we just give T3 all of it instead of just giving T4? Well, T3 has been shown by itself to cause vasoconstriction in the coronary vessels, which can worsen ischemia in a patient who already has coronary artery disease and can also lead to arrhythmias. So this is why we don't administer T3 off the bat. We give low doses of T3 and low doses of T4 so that you don't actually cause harm. So remember also the adrenal glands. And so we should be administering stress dose steroids in this patient population for that concomitant adrenal insufficiency. And I'm typically giving your stress doses like we typically would do. So I'm giving solumedrol or hydrocodone or dexamethasone. The other thing that we want to remember is that our pressors are not going to work unless there's thyroid hormone present. So if we're going to give the steroids, make sure you give the steroids before the thyroid replacement. And then any pressors that we're going to administer, we want to give after the thyroid replacement as well. So pearl number 2, use combination thyroid replacement therapy. Don't just give the T4. If you have a really sick patient in front of you, give combination therapy in low doses. Now we get to the hard part, the supportive care. These patients are hypothermic, they're hypotensive, we're starting to help with their blood pressure, but these patients are oftentimes 31, 32 degrees, and there's a reflexive thing to do, which is to put these patients on a bear hugger or warm IV fluids, which can actually be harmful. So rewarming and causing more harm than good. When we see these hypothermic patients who come into the emergency department with decompensated hypothyroidism, the first thing that we want to do is aggressively warm them because we know that hypothermia is bad for patients. The problem with that is that these patients are maximally as vasoconstricted as they're ever going to be. So if you warm them at all and they're already hypotensive, you're going to actually cause them to vasodilate, which is going to lead to a precipitous circulatory collapse and cause them to probably go into cardiac arrest. So these are not the patients that you want to be aggressively rewarming. These patients need passive rewarming, which consists of a very simple thing, a blanket. Not a warmed blanket, but just a regular room temperature blanket and supplementation of thyroid hormone. So don't be aggressively rewarming these patients. Passive rewarming is the best indication for this patient population. So pearl number 3, passive rewarming and treat the hypothyroidism in order to treat the temperature and prevent the circulatory collapse. The last thing is actually one of my favorite things to talk about, which is what if they're not getting better and you think you want to intubate? We've been talking about intubations that we don't want to happen, and this one is actually a really scary intubation to do as well. So pitfall number 4 is thinking that this is going to be an easy intubation. Most of the time when hypothyroidism patients come into the emergency department, they don't look like this. Angioedema and myxedema can present anywhere, including the face. And so when you have these patients come in and they need to be intubated, they have macroglossia, and they also have edema that presents in their posterior pharynx. And if you think that that's going to be an easy intubation, you have another thing coming. This is a person who we did not have to intubate, but I literally had a blade in my pocket just in case he started to decompensate, thinking I might have to crack this guy. Luckily, we didn't have to do it. So how do we do this safely? Well, we have to remember a couple of things. The primary thing that we have to remember, aside from just the angioedema, is that these patients have literally zero oxygen reserves. So if you RSI these patients, they are going to have a precipitous drop in their oxygen saturation. And it's usually as a result of decreased respirations. So they're bradypneic. They also have pericardial and pleural effusions. And that's all going to lead to decreased oxygen reserves. So if you're going to have to intubate these patients, it should be the expert in the room and only that expert doing the intubation. You might even have to think about doing a nasal intubation. This is not something that we typically do, but this is a patient population where you really want to be concerned about, do I want to RSI this person? The nasopharynx isn't usually affected as much as the posterior oropharynx, and so this is a patient that you may actually be able to get nasally intubated as opposed to using an oral airway. So pearl number 4, intubation of patients with decompensated hypothyroidism should make your anal sphincter tighten up. All right? Experts only. All right. Take home pearls. First thing, think about the thyroid. If they have extremes in vitals, in any altered mental status, it could be hyper or hypothyroidism. But if it's low, think about hypothyroidism. Number 2, dual thyroid replacement therapy. A little bit of T4 and a little T3 has never hurt anybody. Remember also to give them some stress dose steroids before the thyroid replacement. Passive rewarming only for your patients who have hypothermia. And lastly, be careful with any patient with decompensated hypothyroidism if you're thinking about intubating that patient. With that, it's been an amazing conference, and I thank you for your time and your attention.